All right, ladies and gentlemen, welcome to Hall Brill. It's 1 o'clock session and management of unusual traumatic cataracts. And to lead this session, we have Dr. Manish Mahendra from Kanpur. Doctor, over to you. Please unmute.
Thank you, sir. A very good evening to all of you. So we'll be starting with this IC on management of unusual traumatic cataracts. And here we have with us some renowned speakers. We have Dr. Manish Saxena. He's the owner of Shankara Karthik at Kanpur, and he's a renowned vitreoretinal surgeon and a very meticulous and a very patient surgeon. Also, we have with us Dr. Abhishek Dikshit. He's also a very renowned vitreoretinal surgeon from Varanasi, Kashi Netralaya, and his surgical skills are excellent. Still to join us, Dr. Sudhir Srivastava, sir, and I hope that he will soon join us. We would not, Dr. Dilpreet Singh is also one of the panelists, but unfortunately he will not be with us today because his father is not keeping well. So, so he has excused himself from this meeting. So we will miss him. Dr. Sudhir Srivastava, I think he is on his way. He's also a renowned cataract and refractive surgeon from Lucknow, Sun Eye Hospital. He's the owner of that hospital, and he has some wonderful videos. Should we start?
Yeah, I think it's 1 p.m.
Yeah, we can start.
Okay.
You can call the first speaker.
Okay, so ocular trauma is a relatively common entity, and about 1/5 of the population will experience this injury sometime or the other. It's more common in young adults, and the WHO has estimated that there are around 55 million eyes who have ocular injuries annually, and around 1.6 million cases they land up into blindness with this injury. So it's a very dreadful injury, and in developed nations like ours, it's the most cause of unilateral blindness. So it's a really we have to be really concerned of this entity. In our IC, we will be discussing about the management of these unusual traumatic cases. We would be discussing about the pre-surgical consideration, the evaluation and the assessment of these cases, how to go about doing the biometry, the challenges and how to overcome them. And also we will be dealing with the traumatic iridodialysis, how to repair it, and how to give the best results functionally as well as cosmetically. Also, we will be dealing on the vitreoretinal aspect as to how to manage the subluxated traumatic cases, using this sparse planar approach. And finally, we will touch on the role of toric IOLs in managing these post-traumatic astigmatic cases. So to begin with our first talk, we have with us Dr. Abhishek Dikshit, and he will be talking on the entry with caution, pre-surgical consideration. And as I've already mentioned, he's a vitreoretinal surgeon from Varanasi. So over to you, Dr. Abhishek.
Thank you, sir. Am I audible?
Yes, very clear.
Okay, so let's start our presentation. My screen is visible?
Yeah.
So yeah, first of all, thanks to AIOS for giving me this opportunity. And I'm Dr. Abhishek from Varanasi. So let's start with the basics in traumatic cataract patient. So as we know that the traumatic cataract is one of the most common cause of unilocular vision loss in pediatric and younger age group population. We encounter these kind of patients routinely in our OPD. So depending upon the nature and the extent of injury to the lens fiber, these patients can present to us with either in the form of a very linear opacity, which is usually insignificant, or there could be a, like a, you can see here, a rosette shape typical chromatic cataract, or the patient can present with a total mature cataract where the vision is highly affected. So this was a case which came to me around 2 months back, where the patient was a 9-year-old male and had a trauma with stone 2 months back. The patient visual acuity was counting finger close to face, and you can see here the patient IOP was around 16 millimeter mercury, and the patient was on dorzolamide and timolol drops. You can see here a sphincter tear here and here, and the patient, there was a vitreous in AC. Here you can see the vitreous stand is there in the AC, and the nucleus was almost packed, and there was it was a total cataract with anterior capsular tear along this line. So our planning, we did the ultrasound, and the ultrasound, the posterior segment appears to be normal. So we decided to go for lens aspiration and intraocular lens 3-piece along with anterior vitrectomy under general anesthesia. So this was the procedure we did. We stained with the trypan blue anterior capsule to see the margins of the anterior capsule. So whether we can do the axis or not, but it was not possible because the tear was around 180-degree linear. So we started doing the aspiration of lens along with the vitrectomy cutter. This is the cutter we are using. So only we were using the aspiration mode, no cutting mode. Aspiration was around 200. So here also you can see the margin of the tear. At that time, we noticed the posterior capsular tear was also present in that patient. So after aspirating the lens without cutting, after that we stained this anterior chamber with the triamcinolone acetate. Here we are putting the air bubble and then triamcinolone acetate. We are injecting in the anterior chamber, and then we are cutting the anterior vitreous, which is there in the chamber, with the cutting rate around 300 and vacuum around 100. So this is, we are doing the anterior vitrectomy. You can see the one small chunk of the vitreous went inside also. Here, like it went down. So after completing the anterior vitrectomy, we put the 3-piece IOL in the sulcus, and then we close it. The post-operative patient vision was around 6'9" with some glasses, astigmatic glasses. So this was the, sorry. So if a patient comes to our clinic with a history of trauma and cataract, we have to first take history, like most important 3 points. Mode of the trauma, whether it was a blunt injury or a penetrating injury, is very important. Second, the object causing the trauma. What object actually caused the trauma? Because in household materials like knife or all these things, or the pencil or the woods, these objects contain the fungal things. So these there are chances of fungal infection pre or post op. So considering the object is very important in the pre-op and post-op period. And also, if you are suspecting some intraocular foreign body, like the patient had an injury with a chisel, hammer, or some kind of thing. The another third point is duration between the trauma and the presentation. Whether the duration, like the presentation is acute, like within a few days the patient has presented to us, or it's a chronic case where the injury happened a few months back and now the patient is presenting us with the symptoms. So the first thing which comes in our mind is that whether the globe is open or closed. So first we saw the patient, and if we are suspecting that there is some open globe injury or the globe is open, maybe anterior or posterior. So first you avoid touching the object, avoid the devices which touch the eye, like the applanation tonometry or like doing syringing, etc. All these things you should avoid. Or you should also avoid the external pressure on the eye, like avoid doing ultrasound B scan or UBM in an open eye. So now comes to the examination. Examination is broadly can be divided in two parts. Like one is structural examination, which you can do by a torchlight, and you can see the overall structure of the eyelids and orbit. And then comes the functional examination, which is very important. You note down the visual acuity of the patient at the time of presentation, pupillary reaction if it is possible, especially in cases of closed globe injury, and IOP, intraocular pressure. It could be raised, especially in cases of phacoanaphylactic or phacoantigenic kind of thing. or it could be normal, like in self-sealed wound condition, or it could be low, in especially if there is a cyclodialysis or like a ciliary shutdown type of thing. So IOP can vary depending upon the extent of injury. And ocular motility, you have to check whether there is any component of orbital fracture is also there where the muscle is intact. So if possible, you check the ocular motility also. Then coming to the slit lamp, in the cornea, you have to basically see the two things: what is the tissue integrity and what is the tissue transparency. Both of these things are going to affect your surgical management. So first you see the tissue integrity. If there is a corneal tear, definitely you have to do a primary repair. And in the presence of a corneal tear, you should place your sutures perpendicular to the wound, and the wound margin should be exactly opposed to each other. So neither should be too tight or too loose. So this is how you should do a primary repair. And second is tissue transparency. There could be any old trauma which causes the corneal opacity or any leukomatous like a kind of advance. So during surgery, you have to avoid these places because of the induced astigmatism and post-op difficulty in the healing issue. So avoid the existent adherent like opacity in the cornea there, and also it gives a idea about the tonicity of the trauma. So these are the two things you have to assess while preoperatively. And all these things of the corneal curvature changes like corneal scarring, all these things will affect your IOL calculation. So either you can use the other eye to plan your IOL calculation in the IOL to be placed in the traumatic eye, or you can use the average keratometry value of 44 diopter for that eye. Then coming to the anterior chamber examination, any of this, like if there is a hypema present, then you have to first treat it conservatively or surgically, depending upon the amount of hypema and the other things. If there is a cells or fibrin in the anterior chamber, then you have to first start the prednisolone drops and the other cycloplegic drugs, so that the chamber is quiet. Then after you can proceed for the surgery. And if there is a presence or absence of vitreous in the AC, because it gives a clue about the integrity of the zonule, and also if there could be possibility of posterior capsular tear. And the last thing is the depth of the anterior chamber. So anterior chamber depth could be like in a deep in like a posterior dislocated lenses, or could be shallow when the lens is anteriorly subluxated. So depth of the anterior chamber is also you have to look for. Then coming to the condition of the iris, where the iridodialysis is present along with the cataract or not, that you have to repair the dialysis at the same time, or the presence of a sphincter tear, which gives you a patient might have patient would have a post-operative glare on halos because of the sphincter tear. Then you have to counsel before surgery. And gonioscopy in certain cases, where especially in closed loop injuries and chronic cases where you are suspecting the pass or the suspecting angle recession, and you might need a glaucoma filtration surgery later or at the time of your primary cataract removal. So you can plan after, if you are planning for that, you can do gonio also along with that. Then a lens examination, which is very important. Then you have to first look for the capsular integrity. If the capsule is intact, then we can proceed like normally we do 360-degree congruent capsular analysis. But if the capsular tear is present, anterior capsular tear is present, then first you have to try for a 360-degree CCC. But if it is not possible, then you trim the edges of the tears along with the Vannas scissor, so that they don't get entangled in your instrument while doing aspiration or doing removing the cataract surgery, and you try to avoid the undue dialysis of the capsule. And another thing is the amount of cataract. Like if the patient can have a total like a soft cataract where you don't need a cutting, you only need aspiration, or like in old patients with trauma, patient can have a senile component also. So according to that, you have to change your phaco parameters. And the third thing is phacodenesis. Phacodenesis is basically gives you a clue about the zonular dehiscence or zonular injury. So you have to be prepared on the OT table along with your iris hooks or your capsular hooks to support the capsule. And the amount of subluxation and dislocation, depending upon the quadrantic subluxation and dislocation, you have to prepare for either CTR of Shionis ring or SFIOL. Then posterior segment evaluation, if your media is clear enough and you can see the posterior segment, then you can do it direct and we preferably do indirect. So you can do the optic disc and macular evaluation and up to the periphery with indirect ophthalmoscope. And if the media is not clear enough, then you can plan the ultrasound biomicroscopy, like to look for the posterior capsular integrity or for the ciliary body condition, or you can do ultrasound B scan to look for the retinal status. X-ray and CT scan in certain cases where you are suspecting intraocular foreign body or you're suspecting orbital fracture, then you can ask for X-ray orbit or CT scan in these conditions. This is also another thing, choice of anesthesia. We prefer basically general anesthesia in patients of trauma, but and the choice depends upon either whether it's an open case or a closed loop trauma case. In open case, generally we don't give peribulbar injection, but if there is no choice, then you can give 5 ml of peribulbar injection and then you can give further subtenon injection to add on your anesthesia. Try to avoid massaging in these eyes when there is an open globe. Age of the patient, when generally pediatric and younger patient, they require general anesthesia. Health status is the patient condition, like whether it's fit for anesthesia or not. Another thing is estimated duration of procedure. If you are thinking that the procedure will be a long thing, there will be a multiple procedure at the same time, then better to do it under general anesthesia. And surgeon comfort is the last thing. But whatever you feel comfort and the things are available, then you can go ahead with the anesthesia drive. So finally, concluding my remarks, that traumatic cataracts is usually we are seeing in our OPD routinely, and it's a very common case of ocular morbidity in younger patients and pediatric patients. And they are most of the times they are associated with other injuries, like ocular other structures are involved. So that need a thorough evaluation at the time of presentation. And preoperative evaluation is must to determine the best surgical plan to ensure satisfactory and best visual outcome to these patients. Thank you.
Thank you, Dr. Abhishek. That was an excellent presentation. And those subtle inputs are very, very important before embarking on any surgery. And it's really, you need to do a thorough pre-surgical evaluation of any case, be it traumatic or any other case, before you do the surgery. So that was a very nice presentation, Dr. Abhishek. We have with us Dr. Sudhir Srivastava, sir. Thank you for joining us here. And so I think you can start with your...
Sorry for being late, because it was really tough time for me to enter in the session because of the link problem.
Yeah. I know there are some last minute glitches which happen with every one of us. So our next talk will be of Dr. Sudhir Srivastava. Dr. Sudhir Srivastava is a renowned cataract and refractive surgeon. He is the head of Sun Eye Hospital at Lucknow, and he has some excellent videos that we regularly see them on the YouTubes. So over to Dr. Sudhir, and he'll be talking on the biometry challenges in irregular cornea. Sir, you need to unmute. Sir, unmute.
Now my slides are clear?
Yeah, visible? Very much. Yeah, very much.
My voice?
Yes, very okay? Clear, very clear.
Thank you, Manish, and thank you very much for giving me this opportunity. And a special thanks to Scientific Committee AIOS for giving us this platform. Today, I'll be talking about the biometry challenges in the irregular cornea, and especially the post-traumatic cornea, where the corneal scar is there. You all know that the cornea is very important structure, and it is the main optical system because it contributes around 2/3 power of the whole optical system. So any kind of irregularity, especially if it is in the center, definitely it creates a lot of abrasions and a lot of problems, and it kills a lot of vision, quality vision, and on top of that, if the patient develops cataract, and then we have to operate, so getting a proper power of IOLs and proper selection of IOL becomes really very difficult. Slide is, yeah. So no financial interest involved. So suppose the patient has come with the cataract, and now patient has corneal opacity. So what to do? So we do biometry, because you all know that biometry is the target of biometry is to achieve emetropia, and and the proper selection of IOL is very important, because if you have not selecting the proper power, despite of your quality surgery, patient will not be happy. So just to make the happy, to get the end happy, you have to do proper biometry, and especially it becomes really very difficult with the irregular cornea. What happens in the normal eye? Because as we know that because normally we measure the anterior surface of the cornea, and most of the formula, they have the presumption about the posterior surface of the cornea. Because there are only fewer options of equipments are available which measures the anterior surface and the back surface both. So our formulas, they have the presumptions regarding the back surface. So we take the anterior surface readings like keratometries. We do keratometries and we put the data. And according to the presumption, it calculates your posterior surface and you get the keratometry adjustment. Now axial length is important, because now modern formula, they have several other parameters also, like axial length, white to white, anti-chamber depth, lens thickness. They are important. These parameters are also important, especially when we talk about the modern formulas. What happens in the traumatic eye? Now in trauma, suppose that there is a scar on the cornea. So now, because of the presence of the scar, either the anterior surface becomes irregular, or there is a, because if scar either increases the thickness of cornea, or it decreases the thickness if this fibrosis is there. So there is a disturbed correlation between the anterior surface and the back surface. So that it means the presumption will not work here. You have to take the proper measurements. And anterior chamber disturbances might be there, because the whole the iris and lens diaphragm shifts anteriorly or posteriorly. Because of that, your IOL, where you want to implant exactly in the posterior capsule area, it may be slightly anterior or posterior. Keratometry, we can take the help of optical biometers, because this is the end equipments, and it is along with the true K, this is the ideal one. And what happens if we don't have access to the optical biometry? But the main challenge is to achieve the ocular accurate keratometry, because keratometry is very important with the irregular cornea. Even it is more important than the measurements of the axial length. Optical biometer, again, I have no interest, financial interest here. The strap source technology came in 2014. Integration of Barrett suite was there in 2017. Then Total K in 2000, K was incorporated in 2018. And now it has a central 4 millimeter of topography inbuilt. It takes around 45 seconds to gather all informations, and your presumptions, which we used to presume about the back surface, now the presumptions have becomes actually you can take the direct measurements. And with the irregular cornea, topography is very important. So it must be the integral part of your biometry assessment. What happens if you don't have access to that true K? Then what to do? Because these are expensive equipments. So if you have a average practice, and if you have just started your practice, you have simple biometers or keratometers, then definitely to get proper keratometry is really very difficult with the basic instruments. But you can take the if you have multiple devices, you can take the use multiple devices. You can take the multiple readings, and you can get an average to get the better or near normal keratometries. Or if nothing works, then you can take the help of other eye. Then pentacam, again, the EKR value, the keratotic reading is again, it's a quite excellent tool, where it basically assumes the anterior surface and the back surface both, and gives the total K readings. Although the total K reading from the optical systems are comparatively better, several studies have already proven, but pentacam gives some certain clues, especially if you use the EKR values. In case number 1, I want to share a 50-year-old male he came to us, and he was having a mild corneal opacity, and there was a history of trauma, and he was operated elsewhere in Lucknow, and beautiful surgery MICS was done 4 weeks before, and the uncorrected visual vision was 10/400, and the with the correction 5.5 diopters of spherical and 0.75 diopters of cylinder, the patient was improving to 6.9 over 2040. And the K readings were 42.5 because we acquired the K readings and the formulas. So fortunately, we got them. And the K readings which were used at the time of first surgery was 42.5 and 40, and through the manual keratometers. And IVL implanted was the power of implant was 19.5 diopters. And with the outcome with minus, it was slightly towards the myopic side, minus 0.86. Nothing wrong. SRK regression formula was used, and the surprise came with the 5.5 diopters of cylindrical number post-op. So the patient was referred to us for the recalculation of IL power and or the IL exchange or piggyback implantation. We repeated the keratometry, manual keratometry was again 43 average. So because that time the true K was not available with us, so we took the help of Pentacam, and we calculated the EKR through the EKR reports. So the average keratometry came around 39 diopters, less than 40 diopters of keratometry at the 4 mm zone. So the same formula we used again, and the new power came around that was the 26 diopters. So we explanted the previous IVL and we implanted the new implant, and the patient improved as 2020 and with manifest reflection of minus 1.75, because the predicted outcome we already we kept towards the MAPIA side. So this is how sometimes surprises comes if your keratometry is not normal. In case 2, a young female came to us with the trauma perforated anterior capsule with the traumatic cataract, and there was a healed and sealed corneal scar in the center. And this was the you can see the status of the uh, cornea. The cornea was steep. It was around 51.2 or 57 diopters of keratometry, and very irregular surface. Pupil was irregular, and the antechamber depth was raised. All the corneal indices were very alarming. So cornea was highly irregular in this patient. We did holiday EKR detailed report from the Pentacam, and through this basically we take the average of total K. You can in a simpler way you can say that the average K of 4 mm zone or 4.5 mm zone, and then accordingly we calculate the keratometry, and that is an average of that particular zone. So it was around 49 to and 53 with the cylinder of 4.6 through the holiday. And here we did IL masters and the optical system and EKR comparison. And surprisingly, the comparison was almost similar. So we have chosen the IL master reports and calculated the power, and it was around minus 1 diopters, and implanted the minus 1 diopter implant with post-op refraction was 2.5 diopters of cylinder, because the cylinder was very high. This was the surgery. Sorry.
Hello everyone.
So this was the case I took from the archive. This was the condition. The capsule was torn, the perforated with the cortical matter, because patient was young, so there was no nucleus, so it was easier to aspirate. So I aspirated because the surgery, this injury happened at least 4 or 5 weeks before. So the anti-capsule becomes fibrosed and rolled up. So I tried to polish them under the surface of the anterior capsule, but nothing worked. So I implanted the lens first, and then I did I used a vitrectomy cutter to make the capsular axis round, so that it holds the IVL well. And the importance of premium implant is that it must stay in the center, so that just to get the maximum advantage from the lens IVL. In case 3, again, I used 3 instruments, IL Master 1100, then automated keratometer, and the EKR value of pentacam. Here again, you can see that the IOL master readings and the EKR pentacam reports were almost same. Both readings were same, but the automated was at the cylinder was here 0.6 diopter. In the EKR value, it was around 0.6 diopters, but it was here in -3 diopters. So sometimes surprises come. That's why it is recommended you must use multiple instruments to get an idea. So just to conclude, keratometry is difficult and in irregular cornea, and the keratometry is very important, especially when you are using the scarred cornea. Try to trust on the true K values because you'll get quite close to you to the actual keratometry, and always incorporate topography as a biometry procedure, because in the biometry procedure, because you can better counsel your patients, because you know about the cornea. Then EKR, if you have access to pentacam, then trust on EKR value. No instrument is available and 100% trustable instrument is there, and need proper pre-operative counseling is very, very important, because we have to bring the patient's expectation to the reality, and no, never over promise about the results. Do not advise any multifocal or toric IOLs, because patient will not be happy if you advise them. So thank you very much. Over to you, Manish.
Thank you, sir. That was a lovely presentation, and it's really important to do proper biometry. And thank you for clearing our concepts on those important issues on how to handle these irregular corneas and how to do the biometry in these cases. So moving on to the next talk, I'll be presenting my topic. Okay, is the screen, can everyone see the screen?
Yes, sir, we can see.
And I'm audible?
Yes, sir, you're audible.
Yes, sir.
Yeah. Okay, so I'm Dr. Manish Mehndra. I'm working as a senior consultant at Khairabad Eye Hospital, Kanpur, and I'm a cataract and refractive surgeon. So I'll be talking on traumatic iridodialysis repair, modified techniques. Now, we all know that iridodialysis is basically an avulsion of the iris from its natural insertion on the ciliary body that might be accidental or iatrogenic in nature. So whenever we get these cases of trauma, it's very important to not only look at the iridodialysis, but also see the zonules, because underneath these iridodialysis, the zonules can also break. So before you do a surgery, a thorough pre-operative evaluation is a must, and you should always analyze your case and see whether you're dealing with along with the dialysis, you're also dealing with another dialysis that is a zonular dialysis. And if it is so, then you have to plan your surgery accordingly and use CTR rings or other instruments. Again, timing is very important. Whenever we are dealing with these traumatic cases, we know that we will have a lot of inflammation. Patient will come to you with high FEMA, with severe reaction, inflammation. So it's important when to plan your surgery. So you have to treat the eye, make it quiet, and once the eye gets quiescent, then only you need to operate. So the timing is important. Another issue is that you should not wait too long for the surgery, because if you wait too long, then these tissues, they become fibrotic, they become fragile, and then to repair these iridodialysis becomes very difficult. So it should neither be very late, nor it should be early. So I'll be demonstrating my surgical technique here. Now, I'll be showing you a handbag technique. Now, basically what we do here is we make a side put incision, and you use a ninoproline suture, a double arm ninoproline suture. And as you can see here, through this paracentesis, we pass the one end of a ninoproline suture and we take a bite in the peripheral iris, and then also create a scleral tunnel about 2 millimeters away from the damaged iris, and then externalize this needle. And then after we externalize this needle, then we take the other end of the double arm needle, and then with the same method we go and then externalize it through the sclera, and then we pull the sutures and stretch the iris, as you can see here. And once we stretch the iris, then we get a relatively round pupil, and then we tie the knot and bury it. So I'm going to demonstrate you here. Now this was a traumatic cataract with an iridodialysis. So we make a stab incision, and first of all, I use some iris hooks just to stretch the iris and get a more wider and better view. These iris hooks are very good when you're dealing with small people, especially. So I did my capsulorhexis, and this was followed by insertion of the CTR. Now, before this surgery, I saw that there was a small zonular dialysis also, so I implanted a CTR here. And then, as you can see, the cataract is pretty soft, so I did a phaco aspiration here, and then this was followed by an automated irrigation and aspiration, and then the implantation of the intraocular lens. Now then we did, you can see here the iridodialysis, then we did a conjunctival peritomy. I did a wet white cautery, and then made 2 scleral incisions about 2 millimeters away from the sclera, parallel to the damaged iris zone. And this is the scleral tunnel that I'm making. And then I pass my one needle of the ninoproline, take a peripheral bite and externalize it to the scleral tunnel. Now the second needle is being passed in the same method through the peripheral, take a bite to the peripheral iris tissue and then externalize it through the scleral tunnel. Now I will gently pull this suture backwards. Then again, I take another ninoproline suture, do the same method, take a peripheral bite, again externalize it through the scleral tunnel, and finally the last bite adjacent to the initial one, a peripheral bite, and then externalize it through the scleral incision there. You have to be very careful and gentle when you're doing this procedure, because you can further damage the iris and the iris can really bleed here. So be very gentle. And then once you have these sutures, you can tie both the sutures here. And as I'm tying the suture, you can watch the iris getting stretched. You see the iris is getting stretched, the knot is being buried, and now you can see that we have a relatively round pupil. There you see. This was the day 1 post-operative period. And then after a week's period, you can see the iridodialysis has completely gone and we have a relatively round pupil. So pre-operative, you have this picture, and post-operative, a round pupil. So this is important, as the patient will have now less glare. And further on, if you have a very large pupil, then you can further do a pupilloplasty also. So another technique that I'm going to share with you is a modified sewing machine technique. And I would like to just, show an animation so that you can just get clear with the concept, what we are doing here. What we do here is we use a 26 gauge needle, and through the lumen of it, we place a ninoproline suture. Now we make a scleral tunnel, which is again parallel to the damaged iridodialysis, and then we enter the eye through the keratome. And now using that 26 gauge needle, we will now pass it and take a peripheral bite of the iris like we did in our initial case, and then externalize it. Now we will withdraw this suture which was there, and then slightly again withdraw it and take a bite and take a loop out of the 26 gauge needle. Again, we do a similar repeat of the same thing, and then again we finally make 3 loops, and then we will take this, withdraw the needle, the ninoproline, from the lumen of the 26 gauge and pass it through these loops, and then tie the knot. So this, and then the whole thing will get repaired. And I'll show you the case of mine. Now this was a traumatic cataract with iridodialysis, a mature cataract here. So we stained the anterior capsule, we went on to make the capsular access here, and then as you can see, the cataract is pretty soft, so phaco aspiration and then an IA is done. In the similar way, we make a conjunctival peritotomy, again do a scleral tunnel 2 millimeters away from the limbus in the iridodialysis area. And now I'm placing the ninoproline suture through the lumen of a 26 gauge. So I will insert it like a railroad technique and move it forward inside it. And from the opposite end, as you can see here, I will now pull the suture, and I keep pulling it till I let a small tag of the suture in front of the 26 gauge. Now I will place this 26 gauge needle through my paracentesis, take a peripheral bite, engage the iris tissue, again go through the scleral tunnel, externalize my needle, and now I will pull this suture out. See, I'm pull this suture out. Again, now I will slowly withdraw my suture here. I gently withdraw this suture, and now take another bite just adjacent to the initial one, and again externalize it in a similar fashion. Again, I do it at least 3 times, and then I finally withdraw my 26 gauge needle. Here you see, after getting all these 3 loops, I will now gently withdraw my 26 gauge needle and withdraw the needle. There you see the needle of the proline suture. And now I will pass this needle through the loops here and tie and tie. And as I'm tying, you can see that the iris is getting stretched and the iridodialysis gets repaired. And then I cut the ends of the suture and bury the knot. This is followed by the insertion of the intraocular lens and then the removal of the viscoelastic, and I do a cautery of the conjunctiva, and the case is completed. You can see here I have a round pupil there. So the first post-op day, I had a relatively round pupil here. And this is how the case looked. This was the pre-op picture, and this is the post-op picture. So you see the whole iridodialysis gets repaired. And if you have a slittle, there is a little slightly hang back here, but you can do a pupilloplasty also later on to make it further round. So to conclude here, iris repair can be very rewarding both for the patient as well as for the surgeon. And it's important to repair these iridodialysis cases because the patient might complain of a lot of glare, halos, monocular diplopia. So you really need to sit with the patient, understand his problem, and go ahead and explain everything. There are multiple techniques to repair this, and they can be done very successfully. In cases where you have a very large tear, now they have prosthetic devices. They come up with the human optics artificial iris, where you can place this iris on top of the, on the sulcus or underneath the anterior capsulotomy margins, and where you can get a fairly round pupil. So still a lot of research is going on, and you may get some more, wonderful devices in the future. So it's very important to repair these cases to help alleviate the patient's symptoms and enhance cosmesis, as well as give some functional vision to the patient. Thank you. So I would now like to invite our next speaker, and he's Dr. Manish Saxena, a vitreoretinal surgeon from Kanpur. He's the head of Shankar Karthik, and he'll be talking on the pars plana approach, on when to approach through pars plana route for post-traumatic subluxated lenses. Over to you, Manish.
Am I audible now?
Yeah, very much.
My slides visible?
Yeah, perfect.
So thank you, sir. Thank you very much for giving me opportunity to be a part of this IC. And I'm really thankful, this aerodialysis repair, this video I have seen multiple times, and every time I feel like it's amazing. And you are the inspirations to start this techniques, to adopt this techniques. I have also started doing this aerodialysis repair. And today I will be speaking, basically covering the posterior segment part of the trauma. So when to approach through pars plana. So I'm not restricting myself to the traumatic cataract. I'm talking about whole of the trauma and the posterior approach through. So before starting this presentation, I must acknowledge my two mentors, Dr. Mahesh P. Shanmugan and Dr. Madhu Kumar, who taught me everything about retina. And like whatever I am, it's all because of these two mentors. So when to approach through pars plana, a brief introduction has been given by Dr. Abhishek. So I'll just quickly go through. So there are certain indications when we should approach through pars plana. Those are definite indications are the drop nucleus or IOL, presence of any intraocular foreign body, which is in the posterior segment, associated vitreous hemorrhage, retinal detachment, and endophthalmitis. These are the definite indications to go through pars plana route, or subluxated lens or IOL can be dealt with both the approach, anterior as well as the posterior approach. So before managing any kind of patients, the most important I feel is the counseling part, because trauma, it's totally a different game. It's a serious complications. It's a serious issue. So whenever I deal any patients of trauma, I ask my patients along with the attendants to sit down and learn what exactly has happened to the patient's eye, and what we will do. What will be our principle? The principle will always the glow first, not the vision part. So vision we will consider later. First, let us solve the glow. And to do so, we may need multiple surgeries, so that they have to understand. Maybe we'll complete whole of the surgery in one sitting, or maybe or a stage-wise manner, that they need to understand that part. And in trauma, there is nothing like a protocol that we have to follow. It's always the tailored approach. We, according to the patient, we should customize our treatment protocol. The pre-surgical consideration, already Abhishek has mentioned. We need to evaluate whether it's a blunt or penetrating trauma. Patient systemic conditions also needs to be ruled out, because these like diabetes or hypertension, they may result in further complicating your situation. So it has to be dealt as early as possible. Then choice of anesthesia, though in case of penetrating trauma, we always prefer to give general anesthesia. But believe me, the penetrating traumas, most of the time we are doing under local also, without any further complication. But preferable anesthesia in case of penetrating trauma should be general, and local if the blunt trauma, as we do all the surgery. IL calculations and biometry parts, these are as already explained. So the other part is the evaluation of the situations. Evaluation of the situation in terms of how's the cornea is, how's the iris is, how's AC, lens, and the fundus. Everything is important. Even if you are going through posterior, going through the pars plana, if your anterior segment you have not dealt with, then it would be difficult to manage. So whether your corneal entry wound is secured with the suture or not, that needs to be considered before going through the pars plana. Similarly, if there is iridodialysis, then needs to be tackled first, then to go through the pars plana route. Lens evaluations and the fundus examinations, all are important aspects. Apart from the slit lamp examination, B-scan and OCT gives a better tool to diagnose the posterior segment pathology in these trauma cases. So now come to my point, how to manage these subluxated or dropped nucleus. So subluxated nucleus, if you are an anterior segment surgeon, there are various techniques by which you can, try to save that subluxated nucleus to the anterior root. There are fallen vitreous technique, which is called favate, chopstick, like you have to hook the nucleus between the two instrument and take it out. Posterior assisted levitation is one of my favorite. I'll show a small video on the modified version of PAL is the Viscott PAL with Dr. Chan. And if it is dropped completely, then the role of retinal specialist comes, and then we have to use phaco-frag. There are other methods by which we can fill the cavity with the PFCL and bring the nucleus into the anterior part. And third is the internal fixation that I'll show you the videos later. So this is posterior assisted levitation. This is called PAL. Whenever we see any subluxated lens, you just either if you have trocar, vitrectomy trocar system, then put a trocar, and with the help of any instrument, you just push the nucleus into the pupillary plane. Here we are using, it's a YouTube video, it's not my video. So here they have used a 26 gauge needle to push the nucleus into the anterior plane, and then you just go through the anterior segment and take that nucleus out. As I said, the other part is the Viscott PAL, which is like, it's exactly the same, but you put Viscott behind the nucleus so that it will provide a cushion to the dropping nucleus. So here comes my part, which is nucleus or IOL in the vitreous cavity, how to remove that particular part. So whenever there is a subluxated lens or a dropped nucleus, so we try to remove the vitreous first, because we need to pull the nucleus up towards anterior plane. So if we are pulling, if vitreous is there, that will definitely result in a complications. So whenever we have a situation like this, first complete the vitrectomy part, and then switch over your vitrectomy cutter to the phacofragmentome. And with the phacofragmentome, you go into the vitreous cavity with a suction mode only. And then you pull the nucleus into the vitreous cavity. And once it is vitreous cavity, in the mid-vitreous cavity, you try to break the nucleus into multiple pieces with the help of your light pipe. And once there are multiple pieces, then only you start giving the phaco power. And then how you remove the nucleus. While doing this surgery, the most important part is using phaco power. Using phaco power, if you are near to the retina and you are using phaco power at that time, you may end up creating break or other complications like vitreous hemorrhage. So avoid using phaco power when you are near to the retina. Bring the nucleus into the mid-vitreous cavity, use the power, take help of your light pipe, which can feed your phaco probe, and you can remove the nucleus very easily, like the video is showing. So this is the last piece which is gone. Now the surgery is complete. So the second method by which we can remove the nucleus. So this was a case of trauma in which the nucleus was already down. Somebody has put the IOL, and IOL also went down. It was subluxating. So these kind of patients, similarly, first we need to clear the vitreous around the IOL, what we are doing, complete the vitrectomy. And when the vitrectomy is completed, then you start putting the PFCL into the vitreous cavity. Make sure you have to fill whole of the vitreous cavity with PFCL, which will bring all the nucleus or IOL into the pupillary plane. You can see the nucleus sitting over here in the pupillary plane. Then enter through the, make a scleral tunnel, make a sandwich of this nucleus into the vectus and a fish hook, and then you remove. So this is also a very simple way. If you do not have phaco-fragmentome, this is also a simple way to remove this. But while taking out this IOL, you have to be very cautious, because it may, the iris can get stuck to the IOL while pulling. You may end up in complication related to the iris. So you have to be very much cautious about it. So this was the second way of treating this kind of nucleus drop. Third, if there is a trauma and a rigid IOL has been dropped. So there is a novel technique of internal fixation of that dropped PMMA IOL. In this technique, we do not need to take out the IOL. We fix internally itself. So what we do is, basically we complete the vitrectomy part, fill the vitreous cavity with PFCL, and then bring the IOL into the pupillary plane. Now the technique is similar to the scleral fixated IOL. So in our technique, we do not make flap for the scleral fixation. We just make the scleral tunnel and then make 2 holes at the end of these tunnels. So then, similar to the scleral fixated method, these are we are making holes so that you can pass 10-0 proline easily. So once you are done with these holes, you take out the 10-0 proline, go to one end, then through the holes on the optic of PMMA IOL. It's not a scleral fixated IOL, it's a PMMA IOL which was dropped. So we are using whole of that PMA hole over the optic of this PMMA lens to fixate this lens sclerally. So we have created a loop around that hole and the loop on both the sides. So this is a simple technique. You have to go make whole loop through the with the help of these trocars, and once it is done, you have a nicely centered scleral fixation. The advantage of this technique is you don't have to take it out. Post of refractive errors are less. The cost of the IOL you can save. So that is a very good technique to make the IOLs available. So now we have seen how to remove the nucleus if it is dropped, it is in the vitreous cavity. I'll just go through the aphakia part, which after remains managing this nucleus drop. So most of these trauma patients, they don't have a good, they don't have a PC support. So mostly in those cases, we have to focus on this aspect. How's the iris support? Iris is good, support is good, iris support is bad. So if the iris support, iris tissue is good, I prefer to put the posterior iris flow lens. If iris support is not that much good, we prefer to put up a scleral fixated either PMMA lens or scleral fixated lens or multi-piece IOL. So this was a posterior iris curve. It's very easy initial learning curve, but it's a very nice quick method. So scleral fixated IOL, I think I'm having 2 more slides, 2-3 more slides. So the scleral fixated, the technique is almost the same. You complete the vitrectomy part, you make a scleral tunnel on each other side, go through the 10-0 proline, use the 26 gauge needle. If PMMA, then through the holes over the optic, or scleral fixated, then holes through the haptic. And once you have made loops on both the side, then push the lens gently into the anterior chamber. Pull the lens, pull the 10-0 proline from both the sides. You have to be very cautious. Pull equally on both the sides so that you will have a well-centered scleral fixated lens. So these scleral fixated are very good options if iris tissue is not available or tissue is not healthy. And the other scleral fixated part is the glued IOL, in which we use the multi-piece IOL instead of PMMA or scleral fixated IOL. I'll just skip it. So we can see these glued IOLs are also very good options if we are having bad corneas like this. Similarly, these kind of bad traumatic cases in which iris tissue is almost lost, blue diol or scleral fixated IOLs are the best options for these kind of cases. Thank you.
Thank you, Dr. Manish. That was a lovely presentation, some wonderful videos that we saw there. And I think these posterior segment surgeons are, are our saviors. They are saviors of cataract surgeons. Whenever we end up in some complications, they come to rescue us. So thank you so much. And they give a lot of confidence to us, because we know that if we do anything wrong, they are there to help us out. So thank you, Manish, for those wonderful videos. And coming to the next talk is of role of toric IOLs in traumatic cases. And Dr. Dilpreet sir is not here with us. As I told you, his father is not keeping well, so he's involved there. So his talk will be taken by Dr. Sudhir Srivastava sir, and he'll be telling us about the toric IOLs and how to manage these post-traumatic traumatic astigmatic cases. Over to you, sir.
Thank you, Manish. Again, you have given me responsibility, and I wish for Dr. Dilpreet's father's health, and wish that he'll be okay soon. And definitely you'll miss Dr. Dilpreet here. And I have not prepared any presentation yet, but I have two or three slides, so that at least we can discuss, because we all have experience of trauma, especially the vitreoretinal surgeon, Dr. Manish. Saxena Manish has shown beautiful videos. So basically, you said your statement was absolutely right, that without vitreoretinal support, we cannot actually excel. So to do even a good phaco surgery, we need to have a support of a vitreoretinal surgeon. If the person is sitting uh, very close to you, you can do anything. But if the vitreoretinal support is not there, then definitely uh, you'll can't do so many things with the even phaco surgeries, because you'll always scared that what to do when the minor complication would be a great complication. So thank you, Manish, for your very nice video. So I have a few I just picked up a few of slides, very dirty. Um, this optical pyrometry report. Here in this case, you can see that 2K readings were 43.5 and 45.7. The astigmatism was 2.71 diopters. So if you trust only on biometers, and if you're not, as I said in my presentation, that importance of whenever you are going for even any kind of a premium IOLs, and especially the multifocal or toric IOL, you must have the idea about the cornea as a whole. You can't see just, can't trust the only center part of the cornea, because in keratometry, whenever we are just dealing in the center millimeter or maximum 2.8 millimeters of the cornea. So almost all keratometers, but beyond that, a lot of things are hidden. So, like in this report, you can see that the key readings, the astigmatism was 2.71 diopters, but here on the pentagram now you can see the gain. A lot of irregularities in here, and in this area there is irregular oblique, although it is not very clear. And here you can see there is a shift of the pachy apex towards the inferior temporal, inferior nasal area, which is quite uncommon, because whenever we talk about the keratoconus, most of the time we see the shift towards the inferior temporal area, but here it was towards the inferior nasal area. The inner area is slightly towards the inferior medial area, and lot of irregularity. Suppose if you promise the patient and you go with the only with the keratometric readings, and you implant the toric IOLs, this patient will not be very happy, and you won't get the result. Also, you may get some toricities, but sometimes you can create a double toricity in the eye, because you are trying to counter the first one, and you have implanted another toric implant inside the eye, and the both will clash, and a patient will feel hell of the problem. So my suggestion is only that toric is not a problem. You can any time you can start with the toric. It's very easy, because if you are doing excellent phaco, why not to just you're why to deal only with this only spherical component? Because the biometry means what? Why we do biometry? We do biometry to achieve a eumetropia. So why to forget the toricity? So, and we have options, good options, and not very expensive options. So if um, you are a phaco surgeon, every surgeon must try toric, and toric is not a hitch now. So but you must be aware about the even the paracentral part of the cornea and the peripheral part of the sometime a disease might be hidden, and you may operate, and the disease might be progressive. Like if the patient has keratoconus, it may progress in further, and it will again add on the toricity of the cornea. So, or like PED, like if the patient with PED, with it may again progress in future. So, if you know that cornea has something which is hidden, or it has something, some disease which may progress, always try to avoid toric IOLs. And in if you have an irregular cornea because of the suppose because of the injury, so again you have to see that whether it is a regular one or it is irregular. So if you are getting biometry, if you are doing topography and you are getting a symmetrical bow tie pattern of on topography, you can definitely go with the toric implant. But if the toricity is irregular, if the bow tie patterns are irregular, if they are oblique, then don't ever try to implant toric implant IVLs, because this IVL will not work, and in fact it will create a lot of other problems also. It will add on the aberrations of um, uh, in the post-op period. Like in this case, again you can see that toricity is of around 4.3 diopters, but on the topography you can again see a lot of all the corneal indices are abnormal. Here there is a shift towards um, the steep cornea. So these patients are not good patients, and suppose if you think with the experience, you know that the patient toricity is, we can deal with the toric IVL. So always counsel the patient very in the pre-op period, as you have also mentioned and Manish have also emphasized about the counseling. Counseling is very, very important whenever you are dealing with any irregular cornea or any uh, uh, irregular cornea and the cataract, because as I said in my presentation also, that none of the technology is 100% for to achieve an exact amount of the IL power calculation. So if we don't have the exact technology to get best IOL for the choice, then how can we promise? So, in short, I can say that if patient has any irregular surface on the cornea, or if it is even a nebular kind of corneal opacity, or any kind of minor, like SPK sort of things, and you do keratometry, you get some irregularity, and you always try to jump towards the toric IOL, but no, you must try to evaluate the total the cornea in a totality of for topographers, because almost now topographer is a one of the regular tool we can have. All have some sort of, and they are not very pretty expensive also. So always assess the ocular surface, always assess the anterior surface, try to get an idea about the back surface, try to achieve a good keratometry, because now because cornea has a regular surface, it has a scar. You cannot depend on the formulas where the presumptions are already there. So you have to be take proper measurements, then do the biometry, implant the IOL, because now we are experienced, we are doing a lot of good phaco surgery. So definitely surgical part is not a problem, we can manage. So like Manish said that the choices of IOL, if you are not able to implant it in the sulcus, then put it in the then opt for to go for the multi-piece IOLs. And if you are able to implant in the back, then go with the single piece IOL. If there is no support, then you can put on the in the iris, or you can even go for glued IOL or retro iris claw or iris claw. So a lot of options are there now, but still the biometry, again, the question is the biometry will not be 100%. So counseling is very important. Sit with the patient, explain the patient that the reality truth about the corneal status, truth about the IOL power calculation. Patient understands. Most of the time, if you convey in a positive note, patient understand this. So convey it in a positive note and then operate. Definitely, you'll be the winner. So with this, I think I'm sorry because I have not prepared the presentation, but whatever was in my heart, just uh, spoken. So over to you, Manish.
Yeah, thank you so much, sir, for helping us in the last minute and taking that presentation, because I can understand. Uh, so we told you at the end, just a couple of hours before, that you have to go with this presentation. So, but you really did justice to the topic. Sir, I would just like to know that, in case where we are dealing with irregular corneas and we don't have a topography, so how do we, how do we examine those cases? How do we do a preoperative evaluation in those cases?
Manish, exactly. Actually, because everyone has good slit lamps, and if you are regularly, means if you are in practice and if you are examining, doing examination by yourself, then definitely you can get an idea by just simply watching on the slit lamp that something is wrong with on the corneal surface. Whether it is not the ocular surface is not okay. There may be some, some scars, minor nebular opacity. So these patients are not good patients for any, premium IOL. So always try to get an idea. If you don't have access to the topographer, I always say that, and that's why the importance of good practice comes for, especially for the freshers. So if you are doing something wrong, it is not good in modern science, modern period, because the tools are there in the city. Why not to take the help of your other centers? So always, if you have a doubt, then send the patient for topography, send the patient for take the others help, take the seniors help and opinion, and always try to do justice with the honesty, because that is the thing which stays for the longer time, and that will definitely increase your practice in future also. And persistently, if you are doing wrong thing and your patients, you are just operated and your patient is not happy, it will definitely give a full stop. But if you convey to your patient that this problem is there and we may not be able to do certain thing because this tool is not with us, so send the patient to the right center. If even the patient has not turned up you, that patient will be a seat for you in future, because you have already spoken in a very right manner. So I think if simple slit lamp examination and torchlight examination, and you can select, you can see something which is wrong, but you have to see a normal patients, thousands and thousands of normal patients.
I have two doubts. Yeah. First is a patient comes to you with corneal tear and having cataract also. So first question is whether you treat the cataract as a primary procedure at that time, or you wait for some time for the cornea things to settle down and then do the cataract thing as a secondary procedure. And second thing, if you are waiting for a secondary procedure, then how long you wait to or this cornea remodulation and removal of suture and all that thing.
Dr. Abhishek, good afternoon. First of all, your question is absolutely okay, and it's a excellent question, because a patient is having any primary tear on the cornea along with the cataract. So first priority is the close the eye, because we want to save the integrity of the globe, because otherwise patient will end up in the endophthalmitis and other problems. So personally, I prefer, it depends on the patient's patient to patient, because if the tear is anticapsular tear is minor, there is not much of the overflow of cortical matter in the antechamber. So during the aspiration, during the closure of the corneal incision, I simply wash the some amount of cortical matter, but I don't try to remove the whole of the bag, whole of the cortical matter, if the because the possibility of infection is always there. Suppose a patient has come with the sealed corneal perforation, minor entry wound was there and it is sealed, and again the intercapsule is perforated. So try to control the intraocular pressure first and let the patient remain with antibiotic for a couple of weeks time. If there is no endophthalmitis is settling down and there is no progression of infection, you can even delay the patient for the primary surgery for a couple of weeks time. Then in a single way you can do, because then you can get the proper idea of the exactly the situation. You can assess the back surface of the the posterior segment also, and accordingly you can select the IOL and you can do the surgery, cataract surgery, as a primary procedure, like I did in my patient. The patient was having injury. It was she came with the sealed corneal patient with a huge anticapsular tear with a lot of fluffy cortical matter in the antechamber. So I just waited and I kept the patient on anti-glaucoma IOP lowering medications and antibiotics and with the steroids, and I delayed the surgery for a couple of weeks time, and after that I did the surgery and aspirated the cortical matter, and then the cortical matter and the cataract, and implanted the lens. Although because of the delay there was a rolled up anterior capsular margin, so for that I have to struggle with the anterior retractor. So it again depends on the patients. If the wound is quite big and you can't do anything, just close it, because here the idea is just to save the integrity. But if we can do anything to save the vision in future, definitely there should not be any thought. You can do it in as a primary procedure, or you can delay as a you can do the surgery in as a secondary. It
So,
Dr. Abhishek, basically it varies patient to patient. It depends on the amount of tear, amount of cataract, amount of
yeah. So my another thing is that query is that suppose you have applied the sutures, multiple sutures, like it's a big corneal tear. So how long should we wait for the IOL? Like whether all the sutures loosens up and then we remove all the sutures, then do biometry, or maybe after 2 or 3 months we can do the biometry again and do the secondary IOL.
If there is no means there is no anticapsular tear and the cataract is only there because of the blunt trauma, anticapsule is not compromised, then obviously you can delay, because there is no risk of getting post-operative glaucomatous, the glaucoma, traumatic glaucoma because of the fluffy cortical matter. So there in that case you can delay definitely, but otherwise definitely, because if the tear is minor and the patient has less scar, or we always try to wait, because to get the better healing, and so that we can get the better biometry readings. Again, it depends on the amount of the corneal problem. So if amount is less, definitely we expect more. Like our result, we result for we expect for the result that will get definitely get better outcome. If the amount of tear is great, then the we just do surgery just to get avoid the
My
blindness total.
one question from Manish Mahindra, sir. Sir, in your video iodinalysis repair, first video you first put the IOL and then you repaired the dialysis. And the second video you showed, you first repaired the iris and then you put the IOL. Like, is there anything like or protocol like we should first repair the dialysis or then put the IOL?
No,
Or
no,
put the IOL?
there's no protocol as such. It depends upon the visibility and everything. And like in my second case also, I could have put the intraocular lens first and then could have gone for a repair of the iris. And I think it's I just removed the cataract and then did the iris repair and then put the IOL. But I think placing an IOL would be a better option, because it will give us a stability, and especially when we are placing the sutures, we can damage the surrounding tissues also. So if we have the support of the haptic, we get more stability. The support of the intraocular lens, then we get more stability. So that's a
One more
better
question.
option.
These eyes, like traumatic eyes, has inflamed iris basically. Okay. So while putting the suture through it, there could be a drooping of blood in the vitreous cavity. Yes. So any precaution you take during the surgery or any medication or anything you do like to reduce this post-op complication?
Yes, you have to be very meticulous. Actually, that's what I pointed out there, because yes, you are dealing with an inflamed eye, and then when you put these sutures, you are irritating the iris, and then the iris can bleed, and you can have problems there. So yes, you have to be very, very meticulous, very gentle with your procedure, and you need not to be very vigorous. And if you see there is any bleeding, you should go ahead and clean it, wash that area, and be very slow. If you are a little vigorous with your surgery, if you are not patient, then of course you can damage the tissue there.
And sir mentioned about the chances of infection in these patients. So do we do some extra like things like suppose patients has a vegetative kind of injury or metallic injury or whatever. So according to that, do you start pre-op antibiotics like antifungal or antibiotics, or post-op you can add like oral antifungals if you are suspecting that the patient could have vegetative like injury by wood and could have some infection? So do you prefer it or just follow up according to the findings you add on the drugs?
Depending upon the kind of injury that the patient had. So if it's a wood injury, of course, I would like to start with antifungal, drops, and along with antibiotics to prevent a secondary infection. So yes, those cases are very dicey actually, because post-operatively, you're going to have inflammation also, and at the same time, it's a vegetative matter injury. So you have to be very careful and have a very good follow-up of these cases, so that you use antifungal drugs, and then you are controlling the inflammation also with steroids. So you have
because in these patients, what we see in the clinic after trauma, that we see the patient comes from outside and we see all the things are going on, like antibiotic, antifungal, and all kind of drugs are going on. So sometimes we become confused that what drugs do we stop or not, so how long we can continue this antifungal post-operatively. So that's why I'm asking this question.
I think again, seeing at the wound, if the wound is, you've healed it, and there is no infiltrate and there is no reaction, then I think it depends on the case. If the eye is quietening up, then you can withdraw the antifungal drugs and gradually tap on the steroids.
One thing I want to mention with Manish Saxena sir, that very beautiful video sir for nucleus drop, and I have not a very good experience with phaco-fragmentome. So now I try to put PFCL also 1 ml over the posterior pool before starting the phaco-fragmentome, because first time when I was doing the phaco-fragmentome, the nucleus dropped and the macular hemorrhage happened. So that's why.
Yeah, that's initially we used to do that, but what happens, when we put PFCL and doing with the phaco-fragmentome, so you are pulling the nucleus with a suction mode. So most of the PFCL comes first, nucleus later. So this happens. So initially, definitely, I also had multiple, iatrogenic break while doing this phaco-fragmentome. But
and when this phaco-fragmentome, do you use the sleeve, because that thing can cause the scleral melting sometime?
So Abhishek, now earlier I was using 20 gauge with phaco-fragmentome. So the 20 gauge was going through the sclera.
Yeah.
Okay. Now I am having a 23 gauge, which is passing through the trocar. Okay. So when it is passing through the trocar, there are no chances of scleral melting. Okay.
Yeah.
And as I said, scleral melting occurs when you are giving continuous power. So when we are doing phaco in a large vitreous cavity, and that nucleus, you do not have a support system, you are just holding with the phaco tip. So it keeps falling. So we have to give a off period of this phaco power. So when there is on and off period of phaco power, then chances of scleral melting are definitely less. But we have to keep an eye over the sclera entry part, whether how the sclera wound is behaving. If we are using 20 gauge, 23 gauge, we do not have this scleral melting.
I think time is over now.
Yeah.
So
I would like to thank the AIOS scientific team for putting up a wonderful effort here, and coordinating so many speakers at the same time simultaneously is really a great job. And would thank all my speakers, Dr. Sudhir sir, Dr. Manish Saxena, Dr. Abhishek Dikshit. All the presentations were really nice, and some beautiful videos that we all saw. And we missed Dr. Dilpreet Singh, but hope in the future we will have him with us. And finally, I would like to thank the audience for being spending time with us, and I hope we have done justice to our IC, and I hope they gained some message from our presentation. Thank you. Thank you. To the next IC.
Thank you. That was absolutely wonderful session, and what a wonderful speaker panel. Amazing. Thank you so much.